Slide down the suspensory with your left index going around the kidney and press down at insertion, or hook under suspensory and push up. Check you have good clearance of the ovary. Now separate the uterus for better exposure. Form the first millers, nudge down, tighten, and then raise the clamp. Place the second ligature, which can either be a miller's or a surgeon's. Release top clamp, mop up any blood and then raise ovarian clamp. As we no longer have the pressure in the ovarian artery, either a miller's or surgeon's can be placed. Rotate this clamp by placing forceps in the handle. You can visualize the knot and see the tightness. This is great. We can check for bleeding and if any concerns, replace the clamp and add an extra ligature. Easy peasy, better than the conventional way of hanging onto a thread of the pedicle. This is the scary traditional way to check for bleeding, not easy peasy. To reapply the clamp and add a ligation. Swab removed. And now ligation of the broad ligament, but this one has no fat or vessels, so is just torn. Watching this carefully will help you with deeper ovaries. Push down on the abdominal wall with your left hand and pinch the ovary. Once you have pinched the ovary, you can pull hard on it as the vessels are protected by the suspensory and renal ligament. The ovary is a slippery sucker, hence the swab. Hold the ovary with your right hand, slide down the suspensory ligament with your left index finger near the insertion, hook your finger under and push the ligament upwards. There are two ligaments, suspensory and renal. Obviously the renal runs to the kidney. Do not break this as this protects the vessel. Walk the clamp down rather than forcing it. Clamp and separate the uterus. But this is the way you are taught to check for bleeding. Exteriorizing the pedicle from this position is very difficult. The first ligature is a surgeon's, as this is less likely to cut through the uterine than I usually follow with a miller's. Yep, that's not good. It's cut clean through the uterus, but I will still use the knot to ligate the uterine vessels, as it will not cut through these. I feel I need something a little extra for the vessels, so just place an extra surgeon's. I am just checking there is no visual bleeding from the uterine stump. The swab I send in returns with minimum blood, so all good. A simple interrupted was enough to finish the muscle layer, but to spice things up, I ran this into the fat. The advantage of this is the dead space closure. Also, when closing the fat, I will take a nick of the muscle, again to close the dead space, removing any chance of a seroma. I will be unable to tie off and run this into the skin as the needle is too large. The only problem I am going to have is a large knot to cover. As we are starting with a new suture, the subdermal anchor is made above the large fat knot so as to hide it. I went straight into the intradermals as I felt the skin knot would sit caudally before the intradermal entry point. I usually say 2 steps forward, 1 step back. To help burial, pull with some force on the suture, but mainly push the skin over the knot with forceps. You're looking for that tug. If it doesn't bury, retrace the needle out and try again.